Hello, my name is Nicky Harris. I'm a palliative care paediatrician by background, and I'm currently doing a PhD at UE in Bristol about eHealth technology and the delivery of person-centred children's palliative care, which is known colloquially as the MyQuality project. I embarked on this because we all know that caring for a child with complex needs is difficult. It's been described as intensive parenting. We also know that services to meet the needs of the child and family are often fragmented, difficult to navigate, sometimes inadequate, and reports of friction and frustration are sadly common. This situation could be improved by adopting a more person-centred approach to care by healthcare professionals and support services. Whilst there's no agreed definition to this, the focus is on individualising care, encouraging autonomy, sharing power and responsibility, and delivering that within a culture of mutual respect. Isabel Skoll has done some lovely work on this and identifies activities and enablers that are very consistent with good practice in children's palliative care, and the whole process is underpinned by good communication and teamwork. To investigate this, I've used an intervention called MyQuality, which is a website that incorporates individualised outcome measurement, tracking and data sharing options. It was designed for use by children and families with life-limiting conditions and their healthcare professionals. Preliminary research within our local children's hospice suggested that it was welcomed by families, easy to use, and they found it clinically useful and the process was empowering. But I recognised that not everyone in the hospice wanted to engage with that, and we didn't actively seek any feedback from staff accessing data at the time. So further inquiry was needed to really understand what worked and what didn't work, for whom, under what circumstances and why. That process led me to do a realist evaluation. For those of you not familiar with this methodology, the aim is to generate theories to explain how complex interventions work in real life. That knowledge then becomes transferable when you take the theories that you've derived from your specific intervention and apply those and compare them to formal, broader theories about the behaviour of people, organisations and systems. And that allows you to take the learning from your experience and apply that in other settings. Realist evaluation is not method specific, and I've drawn from data from the literature, and whilst there's nothing exactly like MyQuality, there are components of MyQuality in similar interventions elsewhere that we can learn from. I've combined that data with quantitative data from website use and empowerment questionnaires and qualitative data from interviews with key participants, and those have been melded together within iterative cycles of theory development, theory testing and refinement. So over the past 2 years, I've been approaching teams in my local area who support children with life-limiting conditions. They've been given a demonstration of MyQuality and then interviewed about its use, their motivations, their concerns, any practical issues, their hopes for what it could do for them. There were 10 teams who took part, and it was a mixture of professionals, mostly medical and nursing, but also some clinical psychologists, some healthcare assistants, some management staff and so on. If the teams were happy to proceed, I asked them to identify children and families on their caseload who might be interested in using MyQuality. And with their consent, they had interviews and empowerment scales. They were invited to use the website as much or as little as they wished. And that was a minimum of 6 weeks, but sometimes much longer. And then I repeated those interviews and empowerment scales afterwards. And at the end of that process, I went back to the healthcare professionals about their experience of using MyQuality in practice with patients and any challenges that they encountered. And that led to a total of 38 interviews and more than 1,800 days of MyQuality data documented. Distilling all of that revealed 4 main areas of theory development that are listed there. And within each one of those areas, there were a number of specific theories giving more granular detail about what it is about MyQuality that improves communication to deliver person-centred care. And as an example, if I look at this one on the top left here, the first thing that we ask families to do is to highlight specific areas or issues where improvement in their or their child's quality of life is desired. The theory being that keeping those areas clearly in mind will make it easier to emphasise those issues to healthcare professionals in clinical encounters, and that will give a more person-centred focus to the delivery of care. So you come up with a theory that looks like this, and then identify evidence for that through the interview process. In this case, for instance, Daniel's father affirming that the process of working out what we wanted to monitor refocuses your mind on what's going on. And Matthew's mother explaining that that matters because unless you have clear ideas about what you're concerned about in your own mind, it's easy to come out and think, oh, I didn't ask that, or I didn't mention that. So that helps to ensure that the patient's voice is really effectively transmitted within the healthcare encounter. And when you look at the evidence from the clinician's perspective, this quote has come from a community paediatrician whose previous experience had been that when seeing one particular family, that consultations had been very difficult in terms of priority and goal setting. But she said that either mum's become way more articulate, or actually the tool, MyQuality, is a good way of her working out what she wants to prioritise for consultations. Now, the lady was sharing her daughter's MyQuality data with this community paediatrician, but she had a large number of other consultants involved in her care. And the community paed reported back to me, rather to her surprise, that the respiratory consultant in the city down the road had also fed back how clear mum had been about her concerns. So this isn't just about looking at a website to get data, it's about supporting this mother's ability to communicate effectively in a healthcare encounter. So when doing realist evaluation, we look not simply at distilling a few multiple concerns down to a few priority areas in this example. What we actually do is talk about context, mechanism, outcome frameworks to really understand that granular detail of the reasoning and resources provided by an intervention that lead to that outcome. So that if you think back to the intensive parenting, it's that process of reflection and contemplation that brings clarity, that supports confidence, and that helps a parent to then highlight their perspective within a healthcare encounter about their child. And that's what brings about the focus on key priorities. And we've repeated that type of thinking and process and analysis with all of the theories that I showed you on the slides earlier. But there is a fourth area that is worth consideration, and that is that realist evaluation also explores what doesn't work. And particularly when I was discussing using MyQuality with healthcare professionals, they did mention challenges which could result in a spanner in the works and really stopping the process from working. And whether that's at an individual level, that there are concerns about staff who are feeling inadequately resourced, or where they're not feeling as resilient as they might like, or for teams level, it is difficult to change the style, the volume, the nature of your workload without managerial support. And between organisations across services, you really do need clarity about roles, responsibilities, and coordination of services in order to make this work effectively. And without that, some teams found that the opportunities that they could see from this approach to improving communication and working more closely with patients and families could be outweighed by the potential obstacles. It's always difficult adapting to change and new channels of communication and new ways of working. No one wants to feel overwhelmed by the nature of their work, and it is difficult to manage expectation either on an individual patient-family level or when working with your team colleagues, with fellow organisations, or with managers or funders and so on. And so that I did identify quite a number of obstacles that will need to be addressed in order to move this method of communication forward. So the next stages in this process are further refinement of the theory specific to MyQuality, and I need to frame those insights within middle range theoretical perspectives. I'm particularly drawn to Heather Bundage's work about communication theory in relation to patient-reported outcome measures, to the Amenworth and co.'s work about implementation of eHealth, bringing together the individuals, the technology, and the task, in this case person-centred care, and how they fit together, and on a more abstract level, basic psychological needs theory as part of self-determination theory. But after a year where new methods of communication and social interaction involving technology have come to the fore like never before, it's important to consider how we can learn from these new ways of working to support the delivery of care and potentially improve it. And if we do that, then we can all work together to improve the care for children and families who require our support. My contact details are on the bottom. I'd be very happy to take any questions, and I'm very grateful to all those who participated in this study. Thank you for listening.